All right. Well, thank you for having me. And I'm going to talk about monitoring devices and prevention of heart failure. So, all afternoon we have talked about acute decompensated heart failure and how to treat it. And although I do a lot of LVADs and transplants, and according to the Chinese saying, I'm the worst doctor, I'm going to preach prevention of heart failure, trying to be the best doctor today. So, let's see how this goes. Heart failure is very prevalent in the United States. We've got about 7 million patients these days with chronic heart failure, about 500,000 new patients added to the pool every year, about 300,000 patients dying every year. We're spending about $40 billion taking care of these patients per year. Half of them during hospitalization. We spend about half of that money doing that. And despite that, we have a readmission rate in the 20 to 30% and a 5-year mortality, which is fairly pathetic, about 50%. So no matter how you look at it, there's a lot of work that can be done to improve the care of these patients, both on the acute side and the chronic side. We talked about all of this, and in the outpatient side, we have about 11 million clinic visits, about a lot of resources going towards caring for these patients. Now, this is a slide that I showed earlier, last time when I was speaking, but the important thing is this: each sawtooth is an exacerbation. Every time you have an exacerbation, you try to regain back a functional status, which is never the same as where you started off, and hence the trajectory is downwards until you finally end up having an exacerbation where you can't bounce back and you die. If you look at this in real world, these are patients who have had 1 hospitalization versus 2 versus 3 versus 4, and here is the Kaplan-Meier curve in terms of mortality, and you can see patients who have more hospitalizations, they have the worst outcomes. So this is the corollary to this one, where you can see more hospitalizations for heart failure means worse outcomes. If you look at what we have done so far in the last 25 years, we have made sure we look at outcomes based on ACE inhibitors, beta blockers, ARBs, MRAs, and every which way we have reduced mortality. We have looked at CRT and ICD to reduce mortality. However, at the end of the day, if you look at hospitalizations and you look at deaths, they're both on the rise. So at the end of the day, what I said earlier, we have 5 to 7 million patients with heart failure. Every year you have about 500,000 new patients coming into the pool of heart failure. Enormous cost burdens. We got to do something to figure this out. Now, this is something that I think ties in everything that we have talked this afternoon. Why do these patients come back? Why do they come to the hospital? And most of them come with shortness of breath and edema. This is based on over 150,000 admissions on a registry basis, looking at the data. And the causes of readmissions were pretty much failure to receive optimal medications, medication failure, lack of effective outpatient monitoring, readiness with which the patients are dismissed, and then talking about intolerance to potentially life-threatening or life-saving therapies, and lack of economic incentive for taking care of these patients. Most of these hospitalizations are because of volume or volume overload. If you look at the ACC/AHA guidelines right now, they talk about weighing the patients every time they come to the clinic, monitoring, assessing the JVD. But unfortunately, all of these clinical signs are very unreliable, and I'll tell you why. In a study where they looked at patients with a wedge greater than 22, which is a lot of wedge, you can see the sensitivity of various physical signs is anywhere between 13% to 67%, which is the best. So a JVD of greater than 11 is 67% sensitive, but all the other signs for volume overload or a high wedge are pretty pathetic in terms of their sensitivity. The specificity is there, which means if they're present, yes, you figured it out. But if they're not present, you don't figure it out. So why is this important? That's because if you look at it, this is a very good illustration. If this is where you have a heart failure hospitalization, about 3 days before, the patient starts having dyspnea. About 5 days beforehand, you have edema, cough, and fatigue. And all of this symptom complex happens within the 1 week before. If you look at other things such as autonomic variability, thoracic impedance, or pulmonary pressures, you can predict up to 19 days prior to a hospitalization that this bad stuff is going to happen. A patient is going to get admitted. This is another one which is based on a clinical trial that I'm going to review down the road. But this is where on the x-axis you have the PA diastolic pressure, which is sort of a corollary for wedge pressure. And here is the probability of a heart failure event coming down the pike. And you can see right around where you hit about 18 to 20 millimeters of mercury, your risk of having an event is very high. So that's what we're really looking for when you're saying you want to monitor a patient. You want to find whether their PA pressure or PA diastolic pressure is hitting that 18 to 20 crucial range, fix it, and you can prevent possible admission. So how do you do it? You can do invasive hemodynamic monitoring, you can do impedance, you can do heart rate variability. What are these measures? Let's look at this. The first one that was introduced a few years ago was a Medtronic-based device. It was called a Chronicle device, and this is what it looked like. At the end of this sensor was a pressure monitor that sat in the RV outflow tract, and this is sort of a pacemaker thing that sits under the collarbone. And you can implant this, send the patient home, and it would send you details of the patient's PA pressures on a daily basis, and it correlated very well on a right heart cath or a Swan basis. So it basically is an implanted Swan-Ganz catheter that the patient goes home with and can send you the data every day after implant, and you can monitor them on a real-time basis at home. So we did a trial to see if this works. We randomized patients with ejection fraction, about 274 patients, 2 patients who got the Chronicle, and we monitored them, and these patients got implanted, but the doctors or the physicians taking care of them did not have access to the PA pressures. If you look at the outcomes right there, you see that in patients with NYHA3 status, there was a 41% reduction. But this wasn't a pre-specified endpoint. The pre-specified endpoint was all patients, and hence the FDA did not approve this device. So then came the next sensor. And this is just an illustration in terms of hospitalization, and you can see that before the hospitalization, about a week or before, the pressure had started changing, and you could have prevented a heart failure hospitalization. If you look at the efficacy right here, again, this is a 41% reduction in NYHA3 patients if you monitored them and did the therapy. And the thinking was that this result right here was not significant only because the control group got 8 times the amount of nursing visits that one would get if they were not in a clinical trial. So if you had good nursing care, then you could prevent hospitalizations even if you did not have an implantable Swan-Ganz catheter. If you look at what was the next implantable device, this is a PA sensor which is implanted into the pulmonary artery, and you can get the PA pressure recordings. This sensor goes right into a distal pulmonary artery branch and then endothelializes and gives you good pressure readings. This is what the patient goes home with, and this is what we use as hardware to interrogate the device in the hospital. We did a trial naturally to see if this was efficacious. We had about 550 patients in the study. Half of them got the treatment where we monitored the pressures, and half of them, the pressures were monitored, but the doctors did not know the pressures. And the treatment strategy was, if the pressures were high, you got to that 18 to 20 point, you could either do the diuretics, you could increase vasodilators, you could reevaluate the patient, and ultimate treatment decisions were left up to each individual doctor treating the patient. If you look at outcomes, you saw that in pressure-based monitoring, heart failure medication changes happened quite a lot overall versus patients whose pressures were not monitored. If you look at outcomes, in the first 6 months, there was a 28% relative risk reduction versus in over 6 months, there was a 45% reduction in heart failure hospitalizations. So if you actively monitor these patients, you can reduce hospitalizations. This therapy was recently finally approved by the FDA and is now available in the United States for use in a regular NYHA3 patient. This is the same slide. For the time's sake, I'll skip all of this, except this slide, which I think is important. Again, in both cases, in heart failure with reduced ejection fraction and with preserved ejection fraction, you could have a reduction in heart failure hospitalizations utilizing this technology. There's another monitor that you can implant in the left atrium, basically sitting on the interatrial septum, so you can monitor the pressure. This is a very nice device that sits on the interatrial septum, and it communicates to a Palm Pilot or a handheld these days, an app on the phone, and it tells the patient, hey, your LA pressure today is 20, take 20 of Lasix extra on top of your regular Lasix. Your LA pressure today is 30, you need to call your doctor, maybe you need intravenous Lasix. And so this is just like your insulin when you check your blood sugars and you have an algorithm to treat your blood sugars, you have an algorithm to treat your LA pressure. So there's a trial that's happening right now, which will come out in 2017 to see if this is efficacious in preventing hospitalizations. And this is where it sits in between the RA and LA on the interatrial septum. As you can see, the sensor sits and it gives you very nice readings of the LA pressure. Again, there's another technology which is called the impedance monitoring, which basically measures the conductance of electricity across the lung. And if the lung has water in it, then it conducts the electricity really well versus air in it where the electricity is not conducted very well. And based on that, we have devices that incorporate this technology, which is now available in some of the, actually most of the ICD technology that measures the impedance across the lungs and can tell you if the impedance is getting worse and can predict a heart failure hospitalization. So you can manage this with the patient being home and tell them to take extra diuretics if this is happening. The same thing is now available for an office device where if the patient's coming to you in the office, you can measure the impedance and you can look at various parameters, including non-invasive cardiac output measurement and SVR as well. And there is a study that showed that this is fairly good as well to monitor. This is what it's called. It's called the ICG. This is the first derivative of the vector of impedance. This is the ICG score that you get, and you can see that you have an odds ratio of 1.5 for every 1 unit increase in the ICG score. And you can pretty much stratify the patient based on the ICG score in terms of whether they're high risk or intermediate risk. If their thoracic fluid content is high, which means that they're wet, or if the stroke index is high or low, which is the basis of their cardiac output. Based on this, another study was done, which is called the MidHef study, which used the Optival, which is a Medtronic device, and you can see that this is an illustration of prediction of heart failure hospitalization and how one could predict it and hopefully prevent it. Limitations of impedance monitoring, especially with this ICD technology, you have issues in the first 30 days when there's a hematoma and measurement of the impedance is not very good, but otherwise most of the times it's fairly reliable. Heart rate variability is yet another thing that we can measure on a regular basis, especially with ICDs and CRTs, and can help us determine if the patient has poor heart rate variability, and that could signify a worse outcome. I'll skip through this in the interest of time. Home monitoring and telemanagement. Again, Chronicle showed us that if you have good nursing, you can prevent hospitalizations, and this was shown in many other studies as well. If you have various devices such as weight management, blood pressure, pulse oximetry, and so on and so forth, you can reduce bad outcomes in these patients. In our community, we have patients with these devices, and our nurses follow them up on a regular basis, and this is preventing the heart failure hospitalizations. There is a vested interest in this because our hospital gets dinged for rehospitalization in 30 days. So hence, we employ all these techniques to prevent these hospitalizations. Basically, we identify these patients, we introduce ourselves with the letters when they go home. The nurse contacts the patients, tells them, yes, this is how we're going to assess you, and then they stratify the patient as high risk, low risk, and moderate risk in terms of their assessment. They monitor these patients with phone calls on a regular basis based on that, and they report us if there's anything wrong with them, and have the doctors involved in management. And these are various devices that we use for telemonitoring. These are very relevant and useful technologies to prevent bad events in these patients and hence bad outcomes. These are various studies that, in the interest of time, I'm going to skip. But the bottom line is this: if you can take better care of the patient by involving them in their own care, if you can monitor them somehow, whether it's weight-based monitoring or intracardiac hemodynamic monitoring, you can get better outcomes. Thank you again. Questions?